the LMA, or laryngeal mask airway, as part of the NRP Essentials curriculum. Now keep in mind, NRP is a hospital-based course. It is an education program that introduces the concepts and basic skills of neonatal resuscitation. It is not a certification on those skills. I'm going to be covering what to consider in using one, how to insert it, and some perspective. Now, you would consider using an LMA when you cannot ventilate or intubate, meaning ventilation is not successful or not feasible. When resuscitating a newborn with congenital anomalies involving the mouth, the lip, the tongue, the neck, and the palate. When attempting to ventilate a newborn with a small mandible and a large tongue. Where face mask ventilation or intubation are unsuccessful, like with Robin syndrome or trisomy 21. Keep in mind, just because you're having difficulty when attempting ventilation, it doesn't mean you need to jump immediately to alternative airway. The air not going in usually means you need to finish all the steps of Mr. SOPA before you begin airway. Plus, I would recommend my list of ventilatory corrections for airway and seal. I'm going to go through that in just a moment. It's important to remember the alternative airway step in Mr. SOPA, MRSOPA, is the sixth step, the last step, not the first step. So do not jump to the A before you have done the preceding 5 steps before considering that alternative airway. So just to review Mr. SOPA, M is mask adjustment, right? Reapply the mask. I'm going to go through mine in a moment. Reposition the airway. S is for suction the mouth and the nose. O is to make sure the mouth is open. And then P is pressure increase. Now, you may have to increase pressure, but usually you're increasing pressure because you don't have a good seal and the air is leaking out. Then A, which is for alternative airway. The way I describe the ventilatory corrective steps is to think airway seal, mouth open. First, airway. You're going to use a shoulder roll or your hand. So the shoulder roll goes under the shoulder. It's not a neck roll. It's not a pillow. It's a shoulder roll. Meant to lift the chest up so that the head falls back. You may need a bigger shoulder roll on a larger baby or a baby that has a lot of molding. You might have to use your hand if there's 2 people to help do a chest lift. Chin lift is another way to help open that airway. Head tilt. Maybe you're using your hand to help tilt the head back. You could adjust the neck. I've shared in class how a respiratory therapist was saying this is the one way that he uses to constantly tweak the airway so it is the most open while ventilating. You also want to have your 3 fingers on the bony angle of the jaw, lifting the jaw back, or jaw thrust, which is a 2-handed maneuver. Keep in mind that this is not static. It's not like you get it into position and it stays that way. With a very compromised baby, it often takes work, for sure, but you might have to keep tweaking and adjusting because they're so compromised. So it may take more than just one correction. Then the seal. You want to make sure you're pushing on the hard part, not the air part. That the pointy end is toward the nose, if you're using an anatomically shaped mask, and to dry the face. So this is an important step because even though you've dried the baby, they often have moisture oozing out of their mouth or coming from their mouth, and getting a seal on a wet face makes it much more difficult. So you want to be sure you dry the face. Then the next step would be mouth open. You want to make sure the mouth is open because often on compromised babies their mouths are closed like that, but also many of the maneuvers to open the airway close the mouth. Doing a chin lift, right? That kind of closes the mouth. Jaw thrust, if you're not doing it correctly, closes the mouth. It's very easy to close the mouth, so you want to make sure the mouth is open. To remember, again, in Mr. SOPA, the last step is alternative airway. Before I go over insertion, my biggest issue with the LMA has to do with the fear around ventilating, which many people have. But breathing for the baby is the most likely resolution to the most likely problem. And if that's not the problem, if ventilating is not the problem, then I guarantee you the problem is still going to be there. You're not going to create another problem. And last but not least, you're not hurting the baby. And I go over that in much greater detail in Teachable, so if you haven't watched that lecture yet, please be sure to. But back to the fear of ventilating. Because of this fear of ventilating, because of this fear, we tend to rub and flick and stimulate when ventilating is really the most appropriate action. And because of this fear and our lack of ventilating, it's lack of ventilating because we're around so much normal, right? It's rare to have to ventilate, so we don't get a lot of practice. But because we don't have a lot of practice, we're often not good at ventilating, and we're definitely not comfortable with the ventilatory corrective steps, right? And like I say, it's true. Most babies do come around eventually, even though not ventilating the baby that is slow to come around or having difficulty with transitioning, not ventilating that baby is not the least traumatic thing to do, but rather to think this way. You're doing for the baby what the baby cannot do for itself, and which is the simplest, gentlest, most appropriate action. Or stated another way, is doing for the baby what the baby cannot do for itself, and that is to help the baby breathe. So back to the fear issue. Because we rarely need to ventilate, and we rarely do it, there remains this fear, deep fear of ventilating and avoiding ventilating. It is what I have found in teaching over 10,000 people and doing over 1,000 hours of debriefs, that we will do anything but ventilate. And that's how I was taught. You do all these other actions because ventilating, like you don't want to ventilate. But really, what you're doing is you're helping the baby with what the baby can't do on its own. To know that the more compromised the baby, the more work it is to get a good seal and a good airway, because there is no tone in the body to meet the mask and to keep the airway open, even with a decent shoulder roll. So when confronted with a severely compromised baby, we often panic, and if we have hesitation around ventilating, then with the first hint of difficulty in ventilating, we often think, oh, I need more technology, when really you need to do Mr. SOPA and my airway and seal protocol. It takes just a few extra moments to do and to get it to work. So to highlight this, I want to tell you a short, quick story. It's the story of a meconium baby. I was a newish midwife working at a very busy birth center. There is much to this story, but I'm going to focus on the point I'm trying to make here. Basically, a severely compromised baby came out. Gray, lifeless, covered in meconium. I was in shock with what I saw. I had never seen a baby so compromised. Never expected to see a baby so compromised. I left my body, though I was focused on what I knew to do next. I immediately deleted the baby. I dried the baby. I called for another midwife and then started ventilating the baby. The other midwife, of course, called EMS and started listening to the heart rate in the lungs. We did several corrections to get the air going in well, and it took a few corrections. We stopped and assessed a few times, but every time I stopped, there was a dramatic drop in heart rate, so I just kept on ventilating. I always have a heart rate of about 80 beats per minute. EMS came. Basically, the baby went to the hospital and was airlifted to a place where they had ECMO. This is a baby that was so compromised that it probably should have died. But due to a lot of technology, it lived and had a lot of lung damage. And I just tell you that for a bigger perspective. As I said, I learned a lot in this birth on many levels, but the one thing I know for sure is that ventilating works. Had I stopped to put in an LMA, I'm sure the baby would have died. It couldn't go one moment without air being ventilated. Like, it just wouldn't have survived. If ventilating is working, then there is no need to add an LMA. You should be preparing for transport, which is what I did. Now, had I tried, like I said, to insert something that I was not familiar with, I probably would have focused on that piece that I was not comfortable with, and more, like, how do I get it in? Am I doing it right? I don't feel the resistance. How could I feel what I'm going to go over with you in just a moment, because I was so ramped up on my own adrenaline. And as long as I was ventilating, the air was going in. Like I said, I always had a heart rate of about 80 beats per minute. I never had to do compressions on this extremely compromised baby. I really got it that ventilating works, even in the most compromised babies. So to keep that in mind, the LMA is not to be used just because you have a very compromised baby. It is when you can't intubate or ventilate, and you need to do the ventilatory corrective steps first, which means Mr. SOPA, and I would suggest my airway and seal protocol. Just a momentary pause, because it's a big story to highlight an important fact. That being the impact of fear and adrenaline on your delivery of skills and your proficiency. Do what you know how to do. Practice. Get comfortable with ventilating. Follow my recommendations in Teachable. So a little bit about what I've heard about the LMA in use. I have heard a few stories. Yes, some good responses, because that midwife was not afraid to ventilate and had done it before and knew the corrective steps and had done all of that first. On the other hand, I've heard of not so good outcomes. I once was asked to review a chart that had gone before a medical board. The midwife had inserted the LMA after 15 seconds without attempting the ventilatory corrective step, attached it incorrectly, or didn't attach it as I recall, and it came out while ventilating. So inserting one went against her. So I have some thoughts on who should carry one. I feel like the midwife that knows how to ventilate, that knows how to do the corrective steps, that knows that sometimes it takes work to get the air going in correctly, has possibly ventilated a few times, is not afraid to ventilate when needed, well, then having an LMA on hand might be good for the rare possibility that what you are doing is not working. But the midwife who has never ventilated, is not comfortable with ventilating, does not have the ventilatory corrective steps ready to go in their head, is fearful that they may have to do it, then I would say carrying one might not be a good idea. You have to take what happens in your body when confronted with a severely compromised baby, something that is not talked about in our training and education, the adrenaline and fear that you will most likely feel. You have to take that into account with your skill delivery and access to technology that you've never done before. Okay, now on to how to insert one. So there are 3 types of LMAs. Let me show them here. I highly recommend you watch the videos on insertion, where I have links on how to insert one, especially the NRP video is pretty good. For term babies, you're always going to use a size 1 LMA. One type is the inflatable rim. Now, this is actually large. I don't have the, this is a size 2, and you need a size 1. So I don't have the size 1 with me, so just so you know that this is too large for a term newborn. So For the inflatable rim, you actually have to do a bunch of work first. So it's very easy to overinflate the rim when inserting, thereby breaking your seal. So in order to insert this one, you first have to pull the air out of the rim. Then you're supposed to remove the syringe. You're going to insert this in the dowel. Right-handed, left-handed, it doesn't matter. It's going to be harder to do on the doll because it's so big. But it's going to go again over the tongue, going along the hard palate like so. And then once you're in place, and I'm going to describe that when I go through the eye gel, you then have to screw the syringe back on. Screw the syringe back on and inflate the rim, being careful that you don't overinflate the rim because that could break the seal. Okay, that's one. The next generation was the Air Q. SP works pretty good, I hear. Again, same method. You're going to go over the tongue, along the hard palate. The tip goes along the hard palate till it's in place. And then there is the eye gel. I recommend the eye gel because I have had several EMTs in my class using this particular LMA. Of course, not on newborns, but on the adults and pediatrics, they say it's very easy to insert. So, eye gel. You pull that off. Again, size 1. It comes in a little case that you're going to open and take out. There's the hard ridge back and the mask tube area. So you can do this right-handed or left-handed. The head needs to be in the sniffing position. You want to have the mouth open, right? The head in the sniffing position, the mouth open, and you're going to push the, like I like to say, like this. You're going to have this little open end, the mask part, going over the tongue, like so. It's going to go in. The hard part is going to be running along the hard palate. You want to maintain pressure against the palate and advance the device inwards so that it follows the contour of the mouth and palate until you feel resistance. Once you feel resistance, that's as far as you need to go. You're going to hold the tube steady. You're going to attach your CO2 detector. You're going to hold the tube, attach your CO2 detector, which I don't have here, and then you're going to begin ventilating, like so. You should be able to hear bilateral breath sounds and see chest movement. Within about 8 to 10 breaths, you should be able to get a reading on the CO2 detector. It should turn yellow as the baby starts to exhale CO2. Once it is going in and you want to secure the tube to the face, you're going to take a piece of tape, like so. You're going to attach it to the maxilla, go around the tube, and then back onto the face. Hopefully you have a partner that can do that while you're ventilating, and then you would continue to ventilate. So, as a reminder, I want you to watch those videos, especially the NRP one. It's very good about explaining the insertion into the newborn.